This is The Change Physician, episode 147.
Hey, folks, welcome back to the Change Physician Podcast. It's your host, Dr. Kevin Cuccaro, with my Amazeballs co-host, Dr. Amazeballs herself,
Dr.
Melissa
Amazeballs.
Katie, Dr. Amazeballs. We should get you like some scrubs with that Dr. Amazeballs when you go work with your
balls all over it.
All right. Well, this particular episode is a follow-up for the Curse of Knowledge episode, which I do believe was episode number 143. The Curse of Knowledge, again, for a little quick recap, is the idea is once you know something, you tend to devalue it and or you forget. And when you are a physician or you're in a highly trained specialty, whatever that may be, whether it's medical or not, you have a wealth and depth of knowledge that people don't have. So we tend to both undervalue it and we forget what people don't know. So we tend to not communicate in the way that they understand. So that was the wealth of knowledge. Now, the second half of this, though, is something called information asymmetry. And this was another strong takeaway for me when I first learned this term. And what information asymmetry mean is basically somebody has better information than the other, or somebody knows more than the other person does. And this has huge impacts. In fact, I think most of where it's studied is in transactions, like business processes. Like if in business, if you have more information than whoever you're doing the deal with, you have more power in that exchange, right? You can either value or devalue. You can, simply, why did they pay for it so much? Well, you didn't know there were oil underneath your house or something crazy like that. But for medicine, this comes up all the time. And the biggest thing for me, well, information asymmetry, is this idea of informed consent. So the whole idea being informed consent is that somehow in 5 minutes, we can explain all the details of a procedure, or we can provide recommendations to somebody. And just because we've mentioned it, now they can make an appropriate decision. The fact of the matter is, and please don't put me on, crucify me, folks, is it's simply not true. We can provide information to you of what the risks are, but to have the full understanding of what those risks mean, as well as the probabilities associated with them, it is simply impossible without having all that breadth of knowledge behind it. And the reason this is important is because I do think sometimes people think they can just have someone sign a piece of paper and it somehow removes their responsibilities from that clinical interaction. Or people say, well, they chose doing this after I gave them the informed consent. This comes up a lot of times in procedural-based specialties. Not recognizing how you frame that information, your tone of voice, your body language, how desperate the person is, what the what their receptive state that they're in at this time, all of these factors come in, as well as what their knowledge is. If someone is coming into you for treatment recommendations, I can pretty much guarantee that they don't have all of that background knowledge in order to make a fully informed, symmetric decision. So as a physician, we have a responsibility to really know the data, know the evidence, such that we can give the best recommendations and we can advocate for our patients in the best way. So does that make sense so far? Because this is going to come up for a really important study that I'm going to mention in a second, but I kind of want to check in with you and see your thoughts on that.
Yeah. Well, if you want to go into the study, you can do that first. I've got some thoughts or examples of things.
All right. So my background on this is when I went through my little crisis, and we did a whole episode on this, and I started looking at healthcare as a whole. And one of my things was, if people just knew, they would make good decisions, right? The more I learned about pain, the less I started doing injections. I figured, well, I need to publish more information, or I need to get information out there. And there was actually an organization, I think it was called like informeddecisionmaking.org, that supposedly their whole point was to create these decision-making packets. And these decision-making packets were associated with cost savings and higher patient satisfaction, all the stuff. Immediately rang my little eye, and I'm like, this is something interesting. So then I went out, and they were actually, the study that they were using was actually conducted just north of me, I think in Southern Washington, I can't remember what the healthcare system was. It involved orthopedic surgeons and had to do about knee surgery. And so what they did is they had these informed decision-making packets, and they were giving them to the patients when it came to knee replacements. And the headline of the study, I'm pretty sure it said something like informed decision-making decreases costs and increases patient satisfaction, or oh, that's the golden hand, we're decreasing costs of the healthcare system, but we're actually making people better. But when you actually read the study, a funny thing had happened. So a couple key variables that may not have just jumped out just from the headline of informed consent, or these informed decision-making increases patient satisfaction, decreases costs. One, these were all employed physicians. So their compensation was not necessarily per operation that they did, but because they were salaried for the healthcare system themselves. Second thing, along with this distribution of these packets, the surgeons were told that they were going to be monitored for complications. And so we had a quality measure that was taking place. And then third, they were going to see, the characteristics of the people that they did the operation on, and compare that to this informational packet that they gave.
Mm-hmm.
Now, remarkably enough, yes, people who had the information packets had less complications, fewer costs associated with them, and greater satisfaction. But the people who got the packets were also much more likely to be operated on, because the surgeons started to self-select, and they only offered to the surgery to people who were good candidates for the surgery. So it was not the introduction of the decision-making aid that changed the behavior and improved actually doing appropriate operations on appropriate individuals at the right time. It was the fact that they were monitoring the surgeon's behavior. And that was such it was a shocking moment to me. And the other thing, it was a little bit disheartening, because as a consumer now, it becomes even more important for you to seek knowledge and to find a trusted advisor. And so I'm just going to stop there and let you go, because there's so much more I can talk about, but I don't want to. Yeah.
No, it's good. It brought up so many situations I thought about. From a non-medical standpoint, I just think of like a woman going to get their car done, some car work done, and they don't know anything about cars. And not all women, there's women that know things about cars, but that's definitely the typical thing you think of. But I was thinking of reflecting on, it was actually, I just had a pre-op with a patient today. It just made me think of where sometimes when you think about this curse of knowledge, you don't realize what you know, and all these layered levels of understanding. And you have kind of something presented to you that maybe you want to do the anesthetic a little differently. And you mention to them what you're thinking and why, based on their previous experiences. Sometimes when you deliver that information and you try to tell them this versus this, you can see the little wheels turning in their head almost, where it's like, it looks like they're trying to figure out, like, if they have to make an informed choice between the two, but they really don't fully grasp all of the details behind it. And at some point when I started sensing the way that it was like that person and their spouse was trying to figure out, well, what should we do? I immediately like put the kibosh, not in a nice way. I just said, why don't we gather a little bit of information, and I'm going to kind of give you what I think is the safest for you, makes the most sense for you, and I'll give you my 2 cents on what I think you should do. And to be honest, most people don't even know really what the anesthesiologist is giving or doing for you when you're asleep. But I'm mentioning that I'm going to make an effort to try to do the best thing for you that I think is the safest thing for you in light of your previous experiences. And all of a sudden, I felt like there was a little bit of a relief that came from the patient, because they are trying to make a decision that is so loaded with stuff that they don't even understand. So that's one thing I thought about. Sometimes you can stress the patient that really wants to make a good decision, and they really don't have the resources to do it, even though you, in your mind, the way you're telling the information seems like it's quite like, makes sense. And then the other thing I thought about was situation. Of course, this is gonna be very vague because, you know, I don't want any identifiers or anything. Is that a decision to go forth with the surgery that was probably not necessary, elective, wanted to have it done, known increased risk for certain things that can happen. Surgeon probably encourages that, you know, really wouldn't suggest this, but the patient is insistent because they think they know better. And when the surgeon gives into that, and then something happens, and the risk was there, and then the crappy way that the patient feels, because now they're thinking they're an idiot, because it actually did happen, because the risks are real risks. It's really crappy for everyone involved. And there's a definite asymmetry, no matter because their belief, based on the limited information they have, is in conflict with what the surgeon thinks is best, but wants to keep them happy.
Mm-hmm.
It is an extremely difficult situation.
And that, I think, comes to one of the most difficult tensions of this whole point, like with the curse of knowledge and information asymmetry, is at some point you have to take a stand and to recognize, to do what's best because it's the best thing to do.
Right.
You know, and
even if the patient's not happy,
even if they're not happy, and here's the other thing is, because you hear this stuff and you say, oh well, the physician gave into it, and then people, well, they'll throw up their hands and say, well, they signed informed consent or whatever, but you knew it was wrong. And again, don't crucify me this, but I actually find the liability is the person who has the most information. And if the surgeon goes ahead with that, or the proceduralist, or whoever the hell it is, if you're prescribing a medication, and you know, and you have that depth, and yet you still go before because, oh, the patient satisfaction, or they're going to be angry at me, or the one that absolutely drives me up. This has to do more with procedural specialties. I knew it wasn't right, but if I didn't do it, they were going to go to the quack down the street, which is really actually about justifying it for you, in more often than not. That comes down to again, huge liability, I think, for the person who has that depth of information. You know, you brought up my favorite analogy when it comes to this, which is mechanics.
Mm-hmm.
Like, I think there's so much in common between mechanics and docs. It's like scary. Most of us don't understand our cars, and we go in there and we're hoping that whoever we're working with, and you know, and from the mechanics perspective, we should get a mechanic on the show sometime. I'm sure it's a lot like us, because we don't know how to explain it in a way that they would understand. They say, well, what's wrong with your car? Well, I don't know. I turn the key and it goes, and they're like, this person's a freaking nut job. Like, come on, you know, is it doing this? Or is it turning over? Is the alternator, whatever? And so just like in medicine, you want a mechanic who can diagnose your problem, who can tell you what you need, and can proceed in such a way that's not going to abuse you. Because a dirty mechanic, or they have so much more knowledge than you. They can do lots and lots of stuff. They can treat you really, really well. They can give you free coffee every time you come in. They can make you feel like, oh, I'm the most important individual in the world, but they may not ever actually fix your car. You know, I kind of say is like, if you know your mechanic on a first name basis and you're not a classic car collector, you probably need a different mechanic. Same way as if you have a surgeon, a specialist surgeon that you know on a first name basis for all your procedures done, you probably need a different surgeon. If, and you know, again, outside these, maybe you were in a horrible traumatic accident and you have 65 broken bones, all of them that need to be repaired over a duration of time. Those are very rare.
Yeah.
But if you're going in and you're getting your knee scopes every 6 months until then after you get knee scope after knee scope and this knee scope, and then, whoa, my God, now all of a sudden you have severe degenerative arthritis. Wonder why? Because you've been manipulating a joint. You know, that
you've been sold.
You've been sold. And it is a very rough position, and particularly when we're looking at these numbers, we're looking at patient satisfaction and things, where many people get the impression they need to cater to satisfaction And that's contrary to best evidence, best practice, and best everything else. So information asymmetry, folks, really, really important. And as a physician, you need to understand this, because the people coming into your office, you need to protect them. I mean, you know, there's some people would call it, what is that? The word when you're looking like the fatherly thing, paternalistic. And oh, that's horrible. Well, no, if you have people that you care about and they don't have the knowledge that you do, it is your job to actually have some sort of a paternalistic or maternalistic viewpoint in order to protect them. And in some situations, it's protecting them from themselves.
Yeah. Yeah. I think actually we should exit with that information.
Answer that. Well, okay. Sounds good. Why don't you take us out, Amazeballs?
Yeah. Well, I think those are nicely driven home points that people should really consider. No, I think I'm glad you had that term that I had never heard before, but you see it happening all the time. So I'm glad that you brought it into the conversation. So everything Kevin said. That's a cheap way out. No, I think that if you care, if you want to keep your soul and you don't want other people to feel sold to unnecessarily, and you want to do right by your patient, keep them safe and do the right thing, you have to be aware of this psychological component and this phenomenon that can happen and people can be taken advantage of. And the people that should be listening to this may not ever listen to this podcast, but I hope to God that you guys can share it with people that really need to hear it. And there's plenty of other conversations that go very gently into this topic at times anyway. But thank you for joining us on The Changed Physician. This is Melissa, or I am Melissa Katie, the Challenge Doctor, and I'm with my co-host, Dr. Kevin Cuccaro, and we love sharing our thoughts and our guests and our conversations with you at The Changed Physician. Feel free to join us at the community at thechangedphysician.com, and we look forward to seeing you on the next episode. Take care.
Stay well, folks.